Hello everybody, and welcome to the last episode of the day of Between Two Simulators from IMSH25. 25 years of IMSH, who'd believe it? And today with us we've got Susan Gallagher, who runs the National Bariatric Organisation, and she's joined us to have a short interview. So Susan, thanks for being here.
Thank you, Jim.
Great to hear you here. Really appreciate it. So I just wondered if you could tell us a bit more about yourself, first of all, and how you started out your organisation and why, and your background, just give us a brief introduction.
So I'm a registered nurse.
Yep.
I have a master's degree in nursing and a master's degree in religion and social ethics. And I have a PhD in policy ethics. So really the just distribution of healthcare goods and services. Who gets what? And then as I became interested in caring for patients of size, I became certified in bariatric nursing, and I'm certified in safe patient handling. And so I think kind of all that together is, my direction and what I'm looking at, written a lot of manuscripts, led a lot of professional organizations, and have really enjoyed the opportunity to meet other like-minded folks who are interested in improving care for certain patients, particularly the patient of size.
Yeah.
And so that's kind of driven the National Bariatric Solutions Conference, and my efforts most recently is how do we pull all that together?
Yeah, and so really it's a subject that's not spoken about enough, really. The whole demographic of society is changing with size. I wonder if you could give us some stats for the public of what the real norm is with regards to the size of the patient, obesity, etc.
Right. So we say that right now about 42% of the American population is considered obese, the category of obese, having a BMI greater than 30. I know we don't like to use the term BMI, but we still use it just as a screening number. So we know that we have a high demographic. When I visit hospitals, sometimes they'll tell me they have as many as 85% of patients with BMI greater than 50. So it depends on the demographic, the area within the healthcare facility, but we are seeing increasing numbers of individuals of size in healthcare, accessing healthcare.
Yeah, and I think that's not only in the US, but as well that's echoed around the world.
I think so too.
Yeah. In the UK, we're around about 38% and growing. And across Europe as well, there are variable sort of percentages that are growing. Could you just sort of underline some of the special care needs that patients of size might have compared to patients that aren't quite as big?
So care is something that, there needs to be special attention to care. Of course, we want to care for patients in an equitable way, right? But starting IVs, something as simple as starting an IV is a little bit more difficult. Intubation, surgery with extra fat present, skin fold management, catheterization, probably every element of care. And even if we think of the sensitivity element of it, which I think a lot of times, Jake, patients will delay hospitalization as long as possible because they're embarrassed of their size and they don't want to come in, and they're afraid of what might happen when they do come in or being judged. And so there are delays, so patients are sicker when they get to us as well. I think those are some of the issues that we see. Yeah.
So you think that patients of size, because of a stigma, or because they don't want to come in, the chronic health condition could probably get worse because they've delayed coming to hospital?
I do think so. I think we're seeing some improvement now, but I do know that a lot of times our patients just don't want to come in because they're embarrassed. EMS has a hard time bringing them in, and you're right, they're sicker when they get here.
Yeah, and so. So what are the training shortcomings? Why haven't we been training for this all along? My take on it is, as you know, I was involved with the R42 bariatric mannequin. My take on it is that when you train, you should always train for the worst case scenario. You can certainly do that with a patient the size of a bariatric mannequin. So why do you think it's been so underrepresented in training before?
I think there are a number of things. I think one is there may not be an awareness on the part of leadership to support this. We need to do, my opinion is that a point prevalence that's done in the hospital.
Yep.
How many patients do we have on any one day who have either a certain weight or certain BMI, whatever the criteria is that's used,
Yep.
determine what the need is. It's not just the numbers of patients who come in to see us, Jake, but it's the length of stay as well. And a lot of times the patients will stay with us for a long time. Yep. Now you're asking a much bigger question. You're asking, what are the barriers to this kind of training? I think part is bias, but I think part is that we haven't had equipment. Just because we have equipment that accommodates 1,000 pounds doesn't mean the equipment will accommodate a patient who weighs 1,000 pounds.
Yeah.
Right. So that's really an issue. And the beautiful thing about simulation, and I've just seen this where the lights come on for the healthcare professional, is they put the mannequin or the wearable suit, they put the person, we're going to say person, into a sling or some kind of hard equipment, and they realize that it just doesn't work. The patient's either too wide or there's pinch points, the simulated patient. And I just think that's brilliant when a healthcare professional can say, wait a minute, but I bought this equipment.
Yep.
I thought it would accommodate the patient, and I'm seeing that it won't accommodate my patient, just my patient's weight. I think that's a barrier.
Yeah, I absolutely agree with you. And when we're talking about the other side of it with the unconscious bias, and we've seen it with R42 and other obese tools that are out there. When people first see it, there is almost a shock, expression. Okay, and if we have that in a mannequin, then that's probably translated over to real human beings as well. And so I think we've got a duty as healthcare professionals to get over that unconscious bias, whether it's a real person, whether it's a mannequin, and say, no, this is the norm. This is normal. Okay. So, yeah, I agree with everything you say.
And two things I want to mention around that is that the beauty of the mannequin is that in the training associated with using the mannequin, that discussion can happen. You can say it's the natural response to giggle when we're uncomfortable.
Yeah.
So let's recognize this and let's learn how to manage this.
Yeah.
The other thing I want to mention is that if 42% of us are obese, right? Most of us have someone at home who we love who falls in that category. So we might be thinner people, but we still need to be very sensitive in the presence of one another, because I don't know if you have someone at home who you love dearly.
Yeah.
And so I think it's just really important that we change that whole paradigm of thinking it's okay to make comments when there isn't a person of size in our presence. That's not right. It's
not right. And you're absolutely right. You've sort of triggered on I've got a family member who is obese, and the problem is understanding why they're obese, understanding why they're in that position. And sometimes if you think about hip surgery, for instance, hip surgery or knee surgery, you need hip surgery in countries like the UK. You get put on a waiting list. It's not an insurance-based sort of operation, so you get put on a waiting list. And while you're waiting, you become sedentary and you put on weight and you put on more weight. And it's almost a sort of self-fulfilling prophecy, because you become too heavy for surgery. Because your hip is bad, and you can't move because your hip is bad, and that type of situation, and how sort of conscious these people are of the unconscious bias around them is really a sensitive thing to think about with a family member. Exactly. And we need to understand it as well. And also as well, so we need to understand as well, just to point out to the people that might not have an understanding of why obese people can't have surgery sometimes, or especially orthopedic surgery, is because if you have somebody that's sedentary, that might be overweight, and they haven't lost weight, then when they do lose weight, when they're active again, they've had their surgery done, there's going to be an imbalance with the left leg and right leg. But also there are other clinical risks that come along with it as well. So it's a really interesting thing that it becomes a self-fulfilling prophecy, if you like, with obese people.
Right.
Yeah. So, with regard to the National Bariatric Solutions Conference, I wonder if you could tell us more about that, what you do there, what's happening in the next one, where is in the next one. This is your chance to big everything up, Susan, and tell us, what's in your life and what's going on, and why we should be there.
Well, I'm very excited. This is our third National Bariatric Solutions Conference. The first conference was immensely successful. We had a second one, doubled everything, vendors, posters, attendees, and now we're anticipating the third. We really are looking at bariatrics, or caring for the plus size patient, in a holistic manner. We have obesity policy conferences, we have metabolic surgery conferences, but to have a national, or really international, because we have people come from all over the world, to have an international conference that talks about all those elements, the patient handling part of it, the early mobility part of it, skin, critical care, health and well-being, all those things, kind of pulling them together because they are intertwined. We can't do skin care without having patient handling equipment. Right? We can't do critical care without understanding early mobility and the person of size. And so, we do cover all those topics, some very broad, some very specific. We have guests join us, Miss Tracy Cars from the UK. She weighs probably between 480 and 500 pounds. I'm not quite sure. But lovely woman who shares her lived experience. And it's really good because for us to understand, what is it like, or what can we do differently, to hear that from Tracy or from Sarah Bramblett here at the Obesity Action Coalition in the States, will join us in the fall. To hear from those individuals of size, to be able to share with us, I think is really, really great. So we've had a wonderful opportunity to share thoughts. I would encourage any listeners who have a project that they want to do as a poster to contact us. But yeah, we're really excited about that. The conference this year is November 4th through the 7th. We have up to 18 hours of simulation, so that's hands-on, which people really need that to feel a level of confidence. And then a lot of breakout sessions, general sessions, and we have over 40 vendors who have really specific products. So for someone who's looking for something in particular to help their organization provide what I call that safe, equitable care, this is really the place to be, Jake.
Brilliant. And I'm sure it's going to be even busier
I think it'll be
this
really
year
fun.
than it was last year.
Planning for it.
I just finish up on a question about simulation.
Right.
The products within simulation and the simulation community, do we have a duty as an industry to ensure that obese people of size, are represented more in simulation? And what do you think we can train with, what scenarios that we can do when we're using tools in medical simulation to represent people of size?
I do strongly believe, and that's one of the reasons why I'm here this week, that we need to include the mannequins who are size appropriate. So even when we think about the R42, that mannequin represents about a 330 pound person, which is still on the low end, of plus size person. But we need to have those, and we need to use those for training all kinds of things. I think about car extraction, how frightening that is for a family member to bring a patient up to the ED and have no one that knows how to take that patient out of the car, right? Fall recovery. How often are workers injured when they're asked, when they want to get the patient up off the floor and they just can't get a 330 pound person up off the floor. So all of those kinds of things, transfers, toileting, car extraction, it just feels so low tech, but it's so important for our patients, even turning and repositioning, right? Otherwise, patients can develop pressure injuries.
Absolutely. And I think we've found that out during COVID as well. So patients of size that need to be pruned during a COVID situation.
Exactly.
Yeah, yeah. Well, I mean, it's fantastic to have you here, like we said. Thank you for doing this interview with us. And we really admire the work you're doing to highlight, the needs for bariatric patients overall. It's good that you're there on the stand with an Sony and talking about R42. So, yeah, thank you very much,
Yeah,
Susan.
thank you.
And we really appreciate you coming along. Thanks.
Thank you so much,
Thank you.
Jay.
Cheers.